So, coming to the first one, a 72-year-old woman is brought to the ICU in midwinter after being found unresponsive at home. She has a history of hypothyroidism but stopped taking her medications several months ago. On examination, her core temperature is 32 degrees Celsius, blood pressure 80 by 50 mmHg. Heart rate is 42 millimeter of for heart rate is 42 beats per minute, and she is drowsy with dry puffy skin and delayed reflexes. ECG shows a sinus bradycardia with low voltage complexes, and the labs reveal hyponatremia with sodium being around 122 millimole per liter, glucose 58 mg per dl, and markedly elevated TSH with low level of the free T4. So, which of the following is the most appropriate initial management step? Option A, IV levothyroxine alone. Option B, IV hydrocortisone before the thyroid replacement. Option C, active rewarming to 37 degrees Celsius immediately. Option D, IV liothyronine bolus. So, the correct answer would be option B. That is, prior to thyroid replacement, you need to give injection IV hydrocortisone. Now, why is it so? Because you can diagnose this situation as a case of myxedema coma. Myxedema coma is a rare but lethal endocrine emergency caused by decompensated hypothyroidism, which is usually triggered by infection, cold exposure, or the medication non-adherence. Multisystem slowing results from profound hormonal deficiency, and the clinical manifestations are bradycardia, hypothermia, hypoventilation, hyponatremia, and altered mentation. Critically, adrenal insufficiency often coexists, particularly in the autoimmune thyroiditis or pituitary disease. Administering thyroid hormone prior to cortisol replacement can precipitate adrenal crisis by increasing metabolic demand and cortisol clearance. Therefore, IV hydrocortisone 100 milligrams should be given immediately and then 8 hourly before or with IV levothyroxine, which is 200 to 400 microgram loading dose. However, you need to be careful to avoid the T3 boluses because there is risk of arrhythmia. Supportive care includes cautious passive rewarming, gentle fluid correction, and ventilatory support along with optimum titrated and cautious vasopressor support. So example in this case would definitely be always cover with IV hydrocortisone before thyroid hormone in a case of myxedema coma. The cortisol reserve may be normal, minimal, and death may result if it is omitted. Okay. So coming to question number 2. 36-year-old woman with untreated Graves' disease presents to ICU with agitation, vomiting, fever, tachycardia, and mild delirium. BP 140 by 80 mmHg, core temperature 40.2 degrees Celsius. Heart rate is around 180 per minute, and ECG shows atrial fibrillation with a rapid ventricular response. TSH undetectable and free T4 is markedly elevated. You plan to start antithyroid therapy. So which step must precede the administration of iodine solution? A. Administer propranolol. B. Administer iodine solution 1 hour after profile thiouracil. Administer hydrocortisone, which is option C. And option D. Perform plasmapheresis. So what is the answer? It is option B. Administer iodine solution 1 hour after propyl thiouracil. So this is a case of thyroid storm. And as we know, the thyroid storm, it's a life-threatening exacerbation of thyrotoxicosis triggered by infection, surgery, or abrupt cessation of the antithyroid drugs. Management requires a stepwise blockade of hormone effects and synthesis. Propyl thiouracil or methimazole blocks the organification of iodine and hormone synthesis, while propyl thiouracil also inhibits peripheral T4 to T3 conversion. Iodine solutions like Lugol's iodine or potassium iodide acutely block the release of stored hormones, but if given before propyl thiouracil, can paradoxically supply the substrate for new hormone synthesis, and this is known as the George-Bristow effect. So, iodine must be given after 1 hour of propyl thiouracil administration. Propranolol, this controls the adrenergic symptoms and this decreases T4 to T3 conversion. Hydrocortisone adds adrenal support and inhibits the deiodinase and also treat precipitating causes aggressively. So what is the example? This sequence is very, very vital in the management of thyroid storm, which is first beta blocker, then propylthiouracil, then iodine, and then steroid. Reversing this order can actually worsen the crisis. Coming to question number 3. 48-year-old man with rheumatoid arthritis on long-term oral prednisone about 10 milligram per day is admitted with septic shock from pneumonia. Despite of aggressive fluids and high dose of noradrenaline, his MAP remains 55 millimeter mercury. That is, he is hypotensive. Random cortisol returns at 7 microgram per deciliter. So, what is the next best management step? Option A, ACTH stimulation test. Option B, give IV hydrocortisone 100 milligram stat. Option C, switch to dexamethasone. And option D, await cortisol report confirmation. So the answer is give IV hydrocortisone 100 mg stat. So why is it so? Because in the patient who is chronically on corticosteroids, there is suppression of the hypothalamo-pituitary adrenal axis, and this blunts the stress response during critical illness. So septic shock, refractory to vasopressors and fluids should definitely raise the suspicion for adrenal crisis. Waiting for ACTH stimulation testing risks death. Cortisol assays are delayed and unreliable during acute illness. So if there is any doubt that the patient might be having HPA suppression, then please initiate corticosteroid and do not delay awaiting the test results. Empirical treatment with IV hydrocortisone 100 mg followed by 50 mg 6-hourly or infusion at the rate of 10 mg per hour is both diagnostic as well as therapeutic. Hydrocortisone provides glucocorticoid as well as some mineralocorticoid effect, and thereby this rapidly improves the vascular tone as well as the catecholamine sensitivity. Dexamethasone can be used if ACTH testing is planned, but hydrocortisone is preferred for physiologic replacement. So once stabilized, evaluate long-term tapering or the replacement regime. Example already mentioned, never delay steroid therapy in a shock which is unresponsive to fluids and pressors. Don't test a dying patient. So coming to question number 4. 22-year-old woman with type 1 diabetes presents with Kussmaul's breathing, abdominal pain as well as altered mentation. Vitals, heart rate 124 beats per minute, blood pressure low, 82 by 46 millimeter of mercury, respiratory rate is 34 per minute, labs show glucose of 550 milligram per deciliter, pH of 6.9, bicarbonate 4 millimole per liter and large ketones. So what is the most appropriate first intervention? A. IV insulin infusion. B. 1 liter isotonic saline bolus. C. IV bicarbonate. D. Potassium replacement. So option is B, 1 liter isotonic saline bolus. So the primary cause of morbidity in DKA is profound dehydration from osmotic diuresis. Immediate therapy is restoration of the circulatory volume. Administer 1 liter of isotonic saline over 15 to 30 minutes or faster if the patient is in shock. This improves renal perfusion, enhances the clearance of glucose and ketones, and reduces counter-regulatory hormones. Only after hemodynamic stabilization should insulin be started, typically at the rate of 0.1 microgram per kg per hour. Insulin prior to fluids can worsen hypotension by promoting vascular collapse. Potassium must be checked prior to insulin. Insulin will shift potassium intracellularly, risking hypokalemia. Bicarbonate, yes, it is indicated, but if the pH is less than 6.9 and also there is associated cardiovascular compromise. So, What is the example? Fluid, fluid, fluid. This is the first therapy to be initiated, later on to be followed by insulin. Early volume replacement alone can significantly lower glucose and improve the perfusion before initiation of insulin therapy. So, coming to question number 5. A 68-year-old man with type 2 diabetes presents with confusion and lethargy. His glucose is very high, 850 milligram per deciliter. Sodium is 150 millimole per liter. So, he is having hypernatremia with plasma osmolality being 345 milliosmol per kg, which is also quite high, and pH is 7.35. There are no ketones. So the question is, what is the most important principle of therapy? A. IV insulin bolus. B. Gradual rehydration with isotonic saline. C. Potassium supplementation. And D. Bicarbonate infusion. Let's come to the answer. Answer is, of course, B. Gradual rehydration with isotonic saline. And so, what is this case? This is HHS, previously known as HONK. So, hyperglycemic hyperosmolar state, previously known as hyperosmolar non-ketotic coma. Now, this features extreme hyperglycemia, marked dehydration. There is a fluid deficit even up to 9 to 10 liters, and also severe hyperosmolarity without significant ketosis. Mortality is higher than diabetic ketoacidosis, primarily due to cerebral edema or circulatory collapse from overtly rapid correction. The cornerstone is careful, slow rehydration. Begin with isotonic saline, that is 0.9% NaCl to restore the blood volume. Then switch to hypotonic saline, that is 0.45% NaCl, which is guided by corrected levels of sodium and osmolality. Aim is glucose reduction very slowly, 50 to 75 milligram per deciliter per hour. Excessive correction risks the cerebral edema. Insulin infusion is started only after partial volume resuscitation. Potassium monitoring remains essential. And you should treat underlying precipitant like infection, myocardial infarction, stroke, etc. So, what is the example? In HHS, here also, just like DKA, fluid comes first, but it should be slow correction. Rapid changes in osmolality are much more dangerous than hyperglycemia in itself. Coming to question number 6. 45-year-old man with severe ARDS on mechanical ventilation and sedation. He is ongoing midazolam and fentanyl infusion and also having insulin infusion IV for hyperglycemia secondary to sepsis. After 6 hours, the nurse notes a drop in mean arterial pressure and sluggish pupillary response. Capillary glucose is 28 milligram per deciliter. So, question is, which of the following is the most reliable early indicator of hypoglycemia in such ICU patients? A. Diaphoresis. B. Tachycardia. C. Sudden fall in EEG activity. D. Shivering. So, option is sudden fall in EEG activity.